Hi everybody, it's Lisa with today's Go Live, and we have a very specific agenda today. We're going to be talking about atrial fibrillation and hypertrophic cardiomyopathy, and we're going to be talking about sudden cardiac arrest risk assessment in HCM. So I'm going to give it a few minutes for people to jump in. I know a lot of people were very interested in this topic, so I am going to give it a second for people to come in, and then I'm going to give a couple of little side notes for today's talk. So I'll let y'all join the room. This is the awkward part of Go Lives, is waiting for everybody to show up. Which is a way you could set up the room in advance, get everybody to populate, and then come in. Hey Facebook, I got an idea. Okay, I'm going to say this now, and I hope you've read above or below, wherever the note shows up, because this is going to be a very complex talk today, and I'm going to try to make it as easy to understand for the masses as possible. Please don't ask questions until I do a call for questions. When I see your questions pop up on the bottom of the screen and I can't make them go away when I'm doing a Go Live, it's a little distracting, and this is we're going to go over some really complicated stuff today. And I just want to make sure that we're all on the same path. If you saw my desk, I have like notes and papers and documents here so I don't forget any details. So I want to focus on that. When I say question time, feel free to ask. In fact, if you have a question, as I'm going, type it in, but don't hit send until I say so. That way it'll populate nice and fast. Okay, so we've got 6 people here. I'll wait another minute and we'll get going. And how's everybody doing today? It's a beautiful day here. I just took a walk around the block, which was nice. Need to keep moving. And 7 people and more. I like to try to get the people in the room, even though most of you watch it after I've done it. So we'll get there. All right, I'm going to begin, and I'm going to again state that if you're watching today, welcome. But please hold questions until Q&A time. Type in your questions as they come up, but don't hit send until I ask for them. It's just a little distracting, and I got a lot of documents in front of me today that I want to try to get across to you. Okay, so without further ado, we're going to start with atrial fibrillation today. And we're going to start with the guidelines document. And I think it's important that we all focus on data that is published, things that are known, and there are a lot of lifestyle issues that we can use for discussion on a different level, but let's talk about the scientific proven management strategies for hypertrophic cardiomyopathy, AFib, as we know them today. Now, if you go look up some data on atrial fibrillation, you may see some data that is different than AFib in HCM. Most people in the general population with atrial fibrillation have a normal ventricle, and they don't have hypertrophic cardiomyopathy. Maybe they've dilated, maybe they have something else, but HCM and AFib are kind of like a special little niche of AFib. And it doesn't act the same way as other AFib in a lot of cases. For some people, it's because the ventricle is also affected, so the loss of atrial kick really makes us symptomatic, more so than the average person. So let's take a step backwards, and let's talk about general cardiac anatomy. So the atria is the top chamber of the heart. The left side of the heart is what we're really talking about here. So the left side of the heart, in the atria, the blood goes from the atria through the mitral valve into the ventricle and then out the aortic valve and into the body. So having that atrial contraction to push the blood down into the ventricle gives you volume. When you lose an atrial kick, that contraction of the atria, and you get a fibrillation where it's kind of quivering, you're not getting a good push of blood to the bottom part of the heart, which in part is why people with HCM can be really symptomatic in atrial fibrillation. And if you're obstructed HCM in an atrial fibrillation, you're really symptomatic because you're obstructing and you don't have a lot of blood flow and you're really feeling awful. The higher the rate of atrial fibrillation, the worse you're going to feel. So what do I mean the higher rate? In AFib, the top part of the heart is going at a faster beat than the bottom. So you got quiver, quiver, boom, quiver, quiver, boom. So the right, or the top and the bottom are kind of not in sync at that time. and you're going to have more symptoms because you're getting less blood flow through the body at those times. So what do we do? First, let's talk about diagnostics. This gets a little complicated, as everything is with HCM. So if you feel like you're having atrial fibrillation, what are you going to feel like? A lot of people describe it as a fluttering in the top part of the chest, butterflies in their chest, quivering, just being short of breath. Sometimes people don't actually feel the afib, they just feel the symptoms of the afib. So an exacerbated shortness of breath. How do we tell? There's a lot of ways at home you can tell if you're in atrial fibrillation today. You can get an alive core monitor or similar. Those are the ones that go on the back of your phone. You put your fingers on and it can read it, and it has afib detection. So if you don't have an implantable defibrillator or pacemaker and you're not sure and it's intermittent, you might want to go pick up an alive core monitor and keep that at home. You don't have to use the service to send in to have the analysis done. You can take the PDF that it provides, send it over to your doctor and say, what do you make of this? But the alive core monitor will read atrial fibrillation and give you an outread of AFib. However, if your EKG looks so abnormal that the algorithm doesn't know what to do with it, it's going to give you an inconclusive report. And in HCM, a lot of times it does that because it doesn't quite understand what our ventricle is doing, and because that's abnormal and the AFib is there, it sometimes will not give you a report, not because the software won't do it, because they don't have FDA approval to be diagnostic to that degree. So you may just want to print that out and send that to your doctor. So that's one way of telling AFib from home. The other way is with your devices, if you have an implantable device. So I've spent my morning on the phone with all the device companies checking on the latest technology advances since I've been sick and maybe haven't been paying great attention. I'm going to start talking about the SICD and its detection capabilities of atrial fibrillation. So according to Boston Scientific earlier today, there are now 3 generations of the SICD, which some of you may know about. The first generation has no AFib detection. The second generation has no AFib detection. So if you are first or second generation, it's not going to have any capability of detecting atrial fibrillation. The third generation, which is model number A219, does have the capacity for AFib detection. However, it's not 100% sure that it's going to pick up AFib. It will tell you what's called the V to V interval. So it's ventricular beat to ventricular beat interval. And if there is an impedance in that, that indicates something else is going on, and in all likelihood, that is atrial fibrillation. So that detection module needs to be turned on. So when you go to your EP, you can ask them to turn on the detection module in the model number A219 of the SICD, which is the one that goes on your side, and they can detect the V to V. It's not a 100% guarantee that that's atrial fibrillation, but it's good to keep surveillance, and if you suspect AFib and you have a V to V issue, it probably is AFib. So that's one way to detect. In a traditional ICD, there's 2 ways to detect. And this kind of crosses all of the device manufacturers, so it's really not that important whether you're Medtronic, Boston Sci, St. Jude, or Biotronic. They all basically work the same way. Honey, I'm on the phone. Sorry, I'll have to get back to him later. Sorry, see, lost train of thought. Hate losing train of thought. So in a traditional device, you can set AF detection if you have a dual chamber device. If you have a single lead device, the detection rates vary and the ability to do so varies. Most current devices will also do what the SICD does, which is give a V to V interval, and that is an indication that you might be in AFib. So they can turn that on as a detection mode. If you have a dual chamber device, the atrial lead can pick up AFib, and that's pretty clear cut. Now there's 2 ways on most of the devices to be alerted to atrial fibrillation. Number 1, you can have your doctor change the settings of your device to give you an audible alarm in the event of AFib with some devices. I'm not going to go through each device with you. I'd encourage you to go back to your electrophysiologist's office and say, does my device do this way or that way? And they'll answer your individual questions. because there's too many devices to have me do that. I'd go a little nuts. So what you want to do is ask them to turn on the detection. I know the Medtronic device, you have to be in atrial fibrillation for 30 minutes for it to alarm, but it's accumulative within a day. So if you went into AFib for 10 minutes and then you pop back out, and then you went back in for 10 minutes and pop back out, and a third time, after that third time, it would alarm that you've been in AFib for 30 minutes within a 24-hour period. There's other ones that you can set detections for over an hour, over 6 hours, over 12 hours, and it'll alarm at that point. I'll get into why it's important to know if you have AFib in just a second. So you can set your alarm, but you can also utilize care length monitoring. And that goes directly back to your doctor's office, and they'll be alerted if there was an event of AFib, and they'll know to contact you if there's AFib present. Now, I know some of you are very battery sensitive and want to know if, in fact, it's going to make your device not last as long if you have AFib monitoring on. With a regular ICD, dual-chambered pacemaker defibrillator, the amount of battery utilization for AFib detection is minuscule. However, if you have a pacemaker and not an ICD, the batteries are smaller, and thereby it will actually eat into life, so you want to be careful about using AFib monitoring if you don't really need it, because it's going to take up battery and you're going to need a device replacement sooner than you would have otherwise. So you might want to consider that. What other questions did I have on that one? If you're in chronic AFib, don't put your AFib detection on. You're just going to suck up battery and you already know you're in AFib. So it doesn't really make much sense to be notified in such an event. And that kind of answers that question about AFib. Now let's go to the guidelines document. What's important about AFib management in hypertrophic cardiomyopathy? Now, some of this is pretty basic, and if you've not experienced atrial fibrillation yet, or probably won't, don't worry about this stuff. But 20 to 25% of people with hypertrophic cardiomyopathy are going to experience atrial fibrillation at some point in their disease pathway. So you want to make sure you'll know what to do if that happens to you. So what's the first thing we do with atrial fibrillation? We anticoagulate you, because atrial fibrillation is the leading cause of stroke. So what happens is the atria is quivering and clots form in the atria. And those clots travel through your body, land in your brain, land in other parts of your body. So we want to anticoagulate you. And this is where we use drugs like warfarin or Coumadin, which is the first-line treatment for anticoagulation for most people. But now we have other anticoagulation options on the market, and I'm sure you've seen all the commercials for them. So you've got a lot of different options, and you're going to want to talk to your doctor about which anticoagulation is best for you. If you have issues other than HCM with such things as irritable bowel or any type of ulcer issues, you're not necessarily going to want to use anything but warfarin, because they have more GI bleeds associated with them in some cases. So Eliquis and Xarelto and all those. You want to talk to your doctor and make the best anticoagulation choice possible. And nobody wants to be on anticoagulation, but it's necessary if you're in atrial fibrillation. Now, some people say, well, how much AFib do I have to be in before I need anticoagulation? Well, it depends on your doctor and your risk tolerance. Some people say one episode of AFib is enough to prove that you're going to do more AFib. AFib begets AFib, so they're going to want to anticoagulate you sooner. Some docs will say if you can go AFib free for 6 months or a year, we'll get you off of it. You're going to need to talk to your individual doctors about strategies and your own personal anatomy. So I'm going to pause for a second because I should have explained this before. So what are some of the indications you might be at risk for atrial fibrillation and HCM? Probably the easiest one to use as a predictor is left atrial dementia. The bigger the left atria is, the more likely you are to go into atrial fibrillation. Now, if you're not in atrial fibrillation and you have a very large left atria, you're going to be considered to be at risk for AFib at a little higher rate than others. So you're going to want to make sure that you're watching and you're in a surveillance mode. What are the numbers? A normal left atria is under 4 centimeters. In HCM, we tend to be 4.2, 4.4 in that range because we're a slightly dilated left atria. Once you hit a left atrial dimension of 5.0 or greater, it becomes very difficult for the heart to remain in sinus rhythm. So you're going to want to be careful and keep a really close eye on that. So I kind of went a little out of sequence there, and I apologize. But those are the people who are at higher risk. Now, you can have a preserved left atria being a normal size and still develop atrial fibrillation. Why? Because you have HCM, and the scar that's in the ventricle is probably also in the atria, and that scar tissue probably doesn't conduct as well, we think. But knowing exactly why we go into AFib is still a little bit of an unknown. So if you're an AFib risk and you've experienced AFib, you need to talk about anticoagulation. But more importantly, not more importantly, but also important in a class 1 classification, which is really, really important, and we know this to be true, you want to control rate. So if you have atrial fibrillation and your heart rate normally is, in the 60s, 70s, and with AFib kicks up to the 80s, 90s, that's not so bad. But if you're in atrial fibrillation and your rates are 120, 140, 160, this is a real problem because you're going to be miserable. So we want to bring down the rate as much as possible. Even if we can't break the AFib, if we get the rate down, you're going to feel better, and it's better for your heart long term. So rate control is a term you're going to hear a great deal about when you're dealing with atrial fibrillation. How do you accomplish bringing the rate down? Beta blockers, calcium channel blockers. Basically the same drugs we're using in HCM anyway, but you might need a higher dose. So we want to keep the rate controlled. Now, what meds are we using for this? Disopyramide or Norpace is a great drug for atrial fibrillation, and it is also a great drug for obstruction. So if you're obstructed with AFib, disopyramide or Norpace is your first call drug. Yes, I know it's on shortage right now, but we're fixing that problem, and by the first quarter of next year, we should have it resolved, and manufacturing should be back on pace with what it should normally be. But for now, rather than using Norpace controlled release, you can use disopyramide generic, and it will work, but not as smoothly. You'll still have some peaks and valleys as the CR will. So that is an option. If you have either intermittent, and it's happening over and over again, or chronic atrial fibrillation, you might utilize what's called a radiofrequency ablation, or more currently, the guideline document talks about radiofrequency ablation, but there's some data that says cryoablation might actually be better than radiofrequency ablation. Now, ablation sounds like ablation, right? What is the difference between the two? A radiofrequency ablation kind of hits the top of the muscle and kills the muscle up top, and it's causing the conduction through that part of the muscle to stop. But a cryoablation goes a little deeper into the tissue. And some studies say that cryoablation is more successful than radiofrequency ablation. So you may want to talk to your physician about what form of ablation are they using. Are they using cryo, which is cold energy, versus radiofrequency, which is hot energy, but they burn differently and they deal with the tissue differently. So you'll want to ask about that. Now, some people have recently asked on this page, what do we do about long-term recurrent AFib, and can we do multiple ablations? So here's the reality. AFib, excuse my very technical language here, sucks. And we want to get you out of atrial fibrillation as quickly and as efficiently as possible. It's not always possible, and we'll talk about that in a little while. But you want to try the ablation. But you want to try it with somebody who really understands HCM, AFib. Again, I make a call for centers of excellence here. Some people go to their community-based cardiologists and do it, and things get out of control because they think, oh, well, I'm not doing this, and then they move on to non-reversible steps, which I'll talk about in a little bit. So you want to go really slow, and you want to make sure you're dealing with an expert in HCM, atrial fibrillation. If you need some information on that, call the office. We'll help guide you to those people. You will probably have to travel for that. But you want to make sure that you have somebody who knows what they're doing here, because we're burning holes, or burning lines in the muscle of your heart so that the conduction doesn't go the bad ways. It avoids the parts that are causing the AFib. So they'll do pulmonary vein ablation, so they'll go all around the pulmonary vein and stop the electrical circuits from going in there. Whether they do it with cryo or radiofrequency does seem to matter. So the other way that we can deal with atrial fibrillation management is a maze procedure. I know of one person who did a standalone maze. Their AFib was so intolerable they agreed to open heart surgery just for atrial fibrillation. That's not the majority of people. Most people who have AFib and obstruction will do a combination myectomy maze in one setting. So you're opened once, they do the myectomy, and then they'll do the maze. Again, they can either use like a radiofrequency or a cryo. Normally when you're doing a maze, you're doing a cryo. So these are the options. The other drugs that might be utilized in AFib include sotalol, dofetilide, and I always pronounce this wrong, so I'll just say the brand name, Multac. But Multac really hasn't proven to be very helpful for the majority of people. If you consider, all these meds and you've tried them and it's still not working, there is a drug called Ticasym. Now, Ticasym cannot be prescribed by any doctor on the street. They have to have special training, and there's only special pharmacies that can give Ticasym. The other drug that we really rarely use but could be used would be amiodarone. Try not to use that in young people, but sometimes you don't have a choice because you need to get the rhythm back. So can we go from AFib to a life without AFib? Yes, it's possible, but it's difficult. Once that left atria is enlarged, we might have to agree to live with AFib, and we're going to have to manage it. So we keep the rate down, and then we are also working on watching the anatomy very carefully, because the longer you're in atrial fibrillation, it can actually lead to heart failure. So you're going to have to give really careful evaluation if in fact you're a long-term or chronic AFib patient. Now, some people will take the move to do something called an AV nodal ablation. Now, this is a really controversial issue, especially among AFib groups of patients. They're militantly opposed to AV nodal ablations because we're killing the AV node, and the AV node is where your heart gets its conduction system from. So you're killing that, thereby making yourself pacemaker dependent forever. Your conduction system doesn't come back. So why would we consider doing that? Well, if your AFib is so troublesome and you're so symptomatic, then you're not going to have a choice but to do something to make your life more tolerable. And an AV nodal ablation may be that step. But again, and this one with 900 exclamation points bolded in red, do not do it until you've seen an HCM expert and ensured that there's no other options left available for you. I've spoken to too many people who the local doc said, I can't get this AFib, let's just get rid of that AV node. And young people. And then you're pacemaker dependent forever. And those pacemakers don't last as long as just a primary prevention ICD, which can be 8 or 9 years, and the battery lasts. You're peeling through these batteries. So you're exchanging one set of problems for another, and you actually stay in a form of atrial fibrillation because the AFib is still there, but you're getting a good beat between. So it's fib, fib, beat, fib, fib, beat. So you're getting a good contraction every once in a while, as opposed to just being in constant flutter or fib. So you really want to make sure you know what you're doing there. Now, what else did I have in the AFib world for you? I have lots of notes today. I don't normally do notes for these. I just normally talk, but this is a little bit more technical. I did ask one of the technicians at Medtronic about cryoablation therapy because they provide the tools to do the ablations as well as devices. And there's some really new data on the cryoablation versus the radiofrequency ablation that I found very interesting. And I would encourage you all to have conversations with your doctors on the two variations because there is a difference. We talked about the medications. And the bad news is, I know everybody wants to know what's the answer for atrial fibrillation. There is no good answer for atrial fibrillation in HCM. We're going to manage the rhythm. We're going to keep the rate down. And we're going to try to break the atrial fibrillation if at all possible. But AFib begets AFib. The more you go in it, the more likely you are to go in it again. And it's a cycle. So we want to try to break it early. Anticoagulation in young people, nobody really wants to do it because bleed risks are higher. But I'm telling you, I've had a stroke. You don't want to do that. So please make sure that you're compliant if you're AFib and you take your anticoagulation, and that you're communicating with your doctor on therapy options, because you don't want to have a neuro issue coming forward. So that's about it on atrial fibrillation. I'm going to pause here because we're going to pivot to sudden cardiac arrest risk assessment, and I will take questions now on atrial fibrillation. If anybody has one, hit your little send button now. And I'm going to take a drink. I don't want to start sudden cardiac arrest until I have atrial fibrillation questions. I'll give you another minute or two. If there's no questions, we'll move on to sudden cardiac arrest risk assessment and management. And I just dropped a piece of paper that I need. I'm back. Okay, I have no questions on AFib yet. If you're watching this after it has aired, and this is 12:30 Eastern Time on Thursday, so if you think you're watching me live and it's some other time, it's not live. So you can email support@4hcm.org with your questions, and we'll follow up with them at a later date. So please make sure you do that. Okay, somebody's shredding paper in the next office. It's really loud. Question: Is there an HCM group that is more at risk? There is a checklist on this. I might be able to create one at some point, but it's not going to happen in the next couple of days, I'll tell you that much. Who's higher at risk? The larger your left atrial dimension, the higher your risk. And that information is right on your echocardiogram. It doesn't mean you're not at risk if you don't have a very large left atria, but those who have a large left atria are at higher risk. I need no device to tell me when you're in AFib, because AFib... Now, AFib being painful, that's unusual. It's not normally associated with chest pain per se, but it can just be uncomfortable. So, Beverly, maybe you and I should talk about where the pain might be coming from. Are you also obstructed, Beverly? That might be the issue. Not sure. You're welcome, Tracy. Another second for questions? Comments? 1, 2, 3. Oh, I just got a long one. If you go into a bad AFib and it goes away on its own, should you seek medical attention? Hubby had one the other day, took him to his knees. If his physician is aware that he has atrial fibrillation and he's on the proper medication for AFib and he's anticoagulated, you don't need to run to the hospital every time you have an event, but you need to communicate with your HCM team or your cardiologist that the event was there and how severe it was. I would just put a call into the office saying, I just want to make you aware. I had this episode, it lasted X amount of time. I felt like this. I'm okay now. Just so it's documented in your medical records, so that if it comes time to make decisions on more invasive procedures, slow down. If it comes time to make decisions, they know exactly how debilitating your or your husband's atrial fibrillation is. A stress test does not tell you whether or not you have a dilated left atria. It's in your echocardiogram. It might be in a stress echo report. So you look into your echo report, look at LA dimension or LA diameter, and it'll give you a number. Some reports are by volume, and if it's a volume report, give me a call or drop me an email, and I'll give you the normals on that. I don't have them right in front of me right now. You had a myectomy in May, still went into AFib 6 months later. Hurt like a son of a gun. I would get, Beverly, do you have a device? If so, I would interrogate the device to check the rhythm, and I'd also probably go back and do another stress echo and make sure that obstruction is completely resolved. If there's a residual gradient, it might kick up during the AFib, and it might not bother you at other times. Does paroxysmal AFib, we're going to talk about sudden death risks in a minute, so I'll cover that one in a minute, Oliver. Never say you're sorry for asking questions. I will get angry if you say you're sorry for asking questions. I love your questions. Your questions help other people learn too. Beverly, then I'd put, so you're on Amio. Yeah. Did I mention earlier AFib kind of sucks? So what I would say, Beverly, is make sure that you get an event monitor regularly, and let's see what's going on. Get another stress test, stress echo, and see if there's any residual obstruction. and hopefully we can work on improving your quality of life with AFib. I'm sorry that it's such a bear, but it's a bear. I'm sorry. Okay, I'm going to move on to sudden cardiac arrest risk assessment. And we're going to talk about some new data. I have some new data to share with you. So again, we're going to go to the guidelines document, which is available for download from the HCMA website at any time. So if you're not sure, go back to the guidelines document. You can always read the stuff in the guidelines document. However, when you're reading the guidelines document, read the section that applies to you and your question, because if you read the whole thing, it kind of makes you a little hypersensitive that all these other things apply to you. You're not the whole document. You're little pieces of it here and there, and you'll be different pieces of it throughout your life. So go slow, don't overdo. Okay, so I don't like the terminology in the document, and I'm going to ask them to change it in the future. So it says sudden cardiac death risk assessment. It's SCD. I want to change it to SCA, sudden cardiac arrest risk assessment, because we don't necessarily need to die from cardiac arrest in today's world, because we can manage it and we can turn it around. Now, I've talked to some of you, and a couple of you I saw log on here, who had devices implanted by hometown cardiologists before being evaluated by a center of excellence. And maybe you don't have all of these risk factors, and the doctor just thought, HCM, oh no, ICD, she's covered, he's covered. We don't just throw ICDs in everybody because they have hypertrophic cardiomyopathy. It's not needed. There are people who are low risk, medium risk, and high risk people. How do you figure out who you are? It's actually getting easier thanks to amazing research done by a lot of amazing people, specifically Barry Marin and the work that he's been putting into HCM for 40 plus years. But sudden cardiac arrest numbers in HCM are down to the lowest I think they've ever been, because we're treating more people properly with ICDs. Maybe we're treating more than we need to, but when you're talking about sudden death, I think to err on the side of the caution is probably a little smarter than thinking, no, everything's going to be fine. You only get one chance at this in most cases. So, who should go under evaluation and how often? Every person who's diagnosed with hypertrophic cardiomyopathy needs to be evaluated for sudden cardiac arrest. Period. End of story. And it needs to be revisited about every year, because our knowledge of HCM changes. You change. Your family history may have changed. Everything changes. So you need to say, okay, I looked at this last September. It's time to look at it again. But I do encourage you in between times to put it in a little box and put it away and not think about it all the time. If you've been assessed, you're good for a year or so, get reassessed. And sometimes that reassessment doesn't mean much more than just a conversation with your doctor, no more tests or anything. But you want to make sure that you're keeping up on it. Okay, so I didn't do this at the beginning of this talk, but when we're talking about evaluating based on guidelines, guidelines work on Class 1, Class 2A, Class 2B, and Class 3. Which means Class 1 is, we know this to be true, it's documented in the medical literature, there's either been a clinical trial or enough data to say we know this for a fact. A Class 2A is, it's reasonable based on all of the data that we have and all the research we've done to do this thing. Let me redo that. I said that somewhat wrong. Class 1 is what we should do, and the level of evidence is ABC, and that tells you how many trials have been done or what the basis of the recommendation is. Class 2A is you really should do it, and there's probably really good supporting evidence. Class 2B is it's probably a good idea. There's some data, but it's evolving. And Class 3 is do not do it. It causes harm. It may hurt you, kill you. It's dangerous. So 1, 2A, 2B, and 3. So Class 1, all patients with HCM should undergo comprehensive sudden cardiac arrest risk stratification to determine the presence of the following. Personal history of ventricular fibrillation. So you've already had a sudden cardiac arrest, which might include an appropriate ICD shock, which that's kind of what we're trying to figure out whether you need or not. So that's a risk. Or if there have been any ICD therapies for ventricular tachycardia, so anti-tachycardic pacing. B, family history of sudden death, including appropriate ICD therapy for tachyarrhythmias. So what does that mean? Family history. Well, unfortunately, this document missed a little piece of the equation. So if your parent, sibling, or child had a cardiac arrest, we view them each a little bit differently. Parent, you share the DNA with. Sibling, you share the DNA with. Children, it's not as close. So you can go down the family tree in terms of risk, but going up can be a little bit tricky because your child has a different DNA makeup because the other parent is in there too. So you're closer to your siblings and your parent in this case than potentially your child. So if other people in the family have HCM, it's looked at a little bit differently. So going backwards up the family tree gets a little tricky, so you need a specialist to help figure out whether or not that risk seems to go back up the family tree, or does it just go down. The other thing you need to think about is second-degree relatives. Your uncle died, your aunt died, your cousin died, or had an arrest. Does that have the same value? There's not a lot of data on second-degree relatives. Yet again, you need to speak with a specialist to be able to assess who is at higher risk and whether or not that second-degree relative really impacts you as much. And this is where genetic testing, which is going to be next week's topic, might come in to help. So we'll look at that. Third area of risk assessment, unexplained syncope. This is a tricky one. If you pass out and you're not obstructed, that is bad. If you pass out and you're obstructed, we need to figure out whether it was a hemodynamic response that made you pass out or it was an arrhythmia that made you pass out. They're very different mechanisms. One puts you at risk for sudden death. One means you probably are going to need therapy for obstruction, which either means medication or surgery or alcohol septal ablation. Next area for risk assessment, documented. Please don't ask questions until I ask, because you distract me. I'm sorry. Documented non-sustained ventricular tachycardia. Now here's where it gets tricky. If you have one little run of VT, non-sustained VT, that doesn't mean you run and go get an ICD. It has to be 3 beats or more of 120 beats or higher. So if you have a little run of NSVT and it is only 98 or 110, maybe it's really not so bad. But if you have multiples and they're 3 beats or more and they're over 120 beats, this is what they feel is problematic and you should get a device put in. Some docs will say maybe a little bit more, like 10 beats or 4 beats or 6 beats, but let's use the guidelines and focus on those numbers. So 3 beats or more, 120 or higher. Those are all the top risk stratifiers. So if you have one of those, that's enough to get an ICD. But now we have the class 2As, which are probably really important ones. If your blood pressure blunts or fails to rise on exercise, this needs to be taken under consideration. This is a softer risk factor because, again, you have to figure out whether you're obstructed or non-obstructed because that may make your blood pressure blunt or not. So again, a specialist will help figure these things out. Now, the recommendations do say that reevaluation for risk assessment should be done every 12 to 24 months, and you'll want to make sure that you keep doing that. Now we go into the class 2Bs. This is where we get into that AFib question again. So we're learning more about the class 2Bs, and we've actually learned a lot about them, and I do believe in the next iteration of the guidelines that there will be big changes here. So if you've had cardiac MRI and there is late gadolinium enhancement, so that's scar tissue visible in your heart, everybody's got a little scar with HCM, tiny little pieces of scar, 1-2%, no big deal. But if you have scar that is 10 to 15%, and depending upon your age, they're going to start looking at that seriously. If you are over 15%, that is viewed as a high-risk phenotype. And that is work done by Marty Marin and been published for a while now, and we all pretty much feel confident that that is a real risk factor, and I'm sure will be listed as a class 1 in the next iteration of the guidelines. But in this guideline, it's a 2B. If you have a double or triple mutation, so compound mutations, it is viewed that that is a more severe substrate. So if you just have one genetic marker, okay, that doesn't really matter much for risk assessment. If you have 2, it matters more. If you have 3, it matters more. Now, some people say, well, there's high-risk genes and there's low-risk genes. There's really not a lot of data to support a particular genetic mutation in a single mutation is equal to a higher propensity of sudden death. So we don't use a single gene to determine ICD implantation or not. We look at multiple genes and we look at the family history. Now, here's a tricky one. Severe left ventricular outflow tract obstruction. So if you have high gradients, there is a higher level of cardiac arrest associated with those with high gradients. So how do you treat that? Do you put in an ICD, or do you go ahead and you get rid of the obstruction with surgery? Because we know when we've done surgery, the risk of sudden death drops dramatically in that group. So I would argue that you get rid of the obstruction, not put in a device to protect from the potential disaster. So that is another risk factor. Now, there is a class 3 indication here, which means there's something that can cause harm in the evaluation of risk, and that is doing electrophysiologic testing. So if anybody has had EP testing, they put you under, they try to provoke your heart into dangerous arrhythmias, and there was a time, probably back in the late 80s, early 90s, where a group of people thought this is a really great way to see who's at risk for sudden death. If I tickle your heart and I make it go into arrest, you're at high risk. But it didn't prove out to be true. In fact, quite the opposite. In a laboratory setting, there were a lot of people who underwent EP testing, and they didn't have any arrhythmias. So they were sent out into the world and said, oh, you're fine, you had an EP test. Unfortunately, they weren't fine because nobody looked at the rest of the risk factors. So we know that they're not diagnostic, they're not predictive of whether you're going to have an event at another time. Now, some people might have EP testing as part of the implant process to help regulate what the device settings are. That's a different type of EP testing. So if you're using EP testing for risk assessment, don't do it. It's not worth it. It's harmful. It might hurt you. If you're using EP testing to set your device up, that's an appropriate utilization of EP testing in HCM. So as I went through looking at all this data, and that's the end of the guidelines document, there was a publication earlier this week from the ESC, which is the European Society of Cardiology. And some of you may have found online this risk calculator utilized by the European Cardiology Society of Cardiology. It was actually created by Perry Elliott, and he and I talked about this years ago, and I said, sounds interesting, but jury's out. Let's see how well it works before we start promoting it. And I will tell you, I've used it a lot. It doesn't really change anything that's in the guidelines. It's just numbers put onto the data that's in the guidelines for the most part, but not totally. It's missing a number of components. And because it's missing a number of components, it doesn't have the same amount of value as the guidelines to me. But it does have some utilitarian features that will help you get a ballpark figure. So it only asks your age, your wall thickness. Oh, I'm sorry. Somehow I jumped over a number here. Massive hypertrophy is a risk factor as well. I'm so sorry. So back to a class 1 indication. If your wall measurements are 3.0 or greater, that's a risk factor. I just jumped right over that. My apologies. So if you're going to look at your age, your wall thickness, your left atrial size, your gradient, family history of sudden death, not sustained ventricular tachycardia, and unexplained syncope. Those are the factors. Where I have issues here with the tool, and there's pros and cons to the tools. Number 1, the unexplained syncope. Yes, they ask about outflow tract gradient, but they really don't know whether your syncope was mediated by the gradient or was it an arrhythmia. So, because there's no, what were you doing when you passed out? If you were sitting at your desk, it's not related to your gradient in most cases. If you were walking up a flight of stairs, yes, it probably was. So that's not in here. The other thing that's not in here is the MRI data. Now, I'm sure that they can change it and add that factor once we've validated it as a risk factor, but it's still not there. So this new document came out, and they actually tested the ESC guidelines on 3,700 patients from North America, Europe, Middle East, Asia. So they looked at a lot of patients, and they validated this data. And if Perry Elliott ever watches this, he's going to we'll have a long talk afterwards, because I got some issues here. Number one issue, and I've had this since the onset of this program, or this tool. The risk calculator assumes that a risk between 0 and 4 is low risk, and that's 4%. And this is what percentage chance you have of dying in a year. So let's validate this a little bit further. The average human being, at least American, the numbers in other countries might be a little bit different than this. The average human being has a 0.8% chance of dying in any year. So you're walking out, you're struck by a bus, a bolt of lightning hits you, you have a cardiac arrest, something, you have cancer, you die from something else. 0.8% chance every year of your life that you're not going to make it to the next year. So that's normal risk. So that's okay. That's low risk. But this risk calculator says up to 4% is considered low risk. And I think that's a very individualized decision. Is 3% too much for you to deal with? Is 2% too much if your baseline risk is 0.8? So some people are going to have to make their own decisions on what is low risk to them. But understand the terminology low risk in this risk calculator is under 4%. So that's one group. The median group is between 4 and 6%. So you're considered at mid-level risk if your score is between 4 and 6. If your score is over 6, you're considered high risk. So what did they find when they tested this risk calculator? It's kind of interesting. They found that those with high risk classification, 6% or greater, actually had an 8.9% incidence of ICD discharge. That means that high risk really is high risk, and high risk is validated with this. So there's some utilitarian data from this risk calculator. If you really aren't sure if you're at high risk, this will validate that you are, and in fact you need a device. The low risk group actually had some numbers. They're small numbers, but they're still a little concerning to me. Of the people that were in the low risk group, 1.4% had an incident of sudden cardiac arrest. Now remember, they're low risk, so they didn't get devices. So that's 1.4% died or had an arrest and hopefully were resuscitated. So my deeper question on that particular issue is, the 1.4 that died, were they arrhythmic deaths? Were they heart failure deaths? And the next part is 1.4 really low risk? If 0.8 is the risk of living. So the blurry area here, and I don't blame the calculator for this because it's blurry whether you do it through the guidelines or through the calculator, is what about those middle people? Where do they really sit? What is 4 to 6%? What is really 2 to 6%? Should they be implanted or not? So the risk calculator can help you make some decisions. However, a number is just a number. You really need to look deeply into the data and really need to assess your individual risk tolerance, talk with your doctor, and really make good decisions on when to put in a device. The devices are not, benign. They can come with risks. You can have lead dislodgement, you can have infections, you can have lots of issues. But they do protect you. I lived with a device from 1992 to 2017. Most of my life I had a device. I didn't really have any major complications from it. I love devices. I love device therapy. I know millions, well not millions, but thousands of people who have them and have improved their quality of life either by having the security of having them there or they've appropriately fired and saved their lives. So device therapy is awesome in HCM and it's been a game changer. However, who should get one? When should you get one? When shouldn't you get one? I think this risk calculator, the ESC Risk Calculator, can show you the very, very low risk. So if you're under 1%, that's a no-brainer. Don't do it. If you're over 6%, you definitely are doing it. That middle zone, we're still doing it old school. You're taking the guidelines document, you're looking at all the risk factors, and you're having a conversation with your healthcare provider to determine whether or not you need a device or not. So let's say you need a device, and you're choosing a device. In today's world, we know MRIs are really important in HCM, and in the old days, you couldn't use an MRI if you had an ICD. but you can go online, and I will print this out or publish this shortly. Fortunately, Facebook doesn't let you publish PDFs. But this is the data from Medtronic on all of their MRI-compatible devices, both pacemakers, defibrillators, the monitors, and their associated leads. So it'll tell you which ones are safe to continue having your MRIs in. And we think that that's important. I also have the document from Boston Sci about the AFib battery utilization that I've just gone through. Doesn't seem to be a big deal. ESC document and guidelines document. Now, sudden cardiac arrest risk assessment does not get into treatment so much. I just want to kind of talk about risk assessment today. We know the therapy is an ICD, but there also could be medication management issues that you'll discuss with your doctor. Some people need some pretty hardcore antiarrhythmics. Others will do fine on a beta blocker. But in almost all cases, anybody who has an ICD is probably going to be on some level of medication as well. I will take your questions now. I think I kind of handled it all. Just looking around to see if I missed anything. Oh, there is one other classification that isn't really covered in the guidelines for ICDs, and that's people with blunted or low ejection fractions. There's some data that suggests those who are going into an end-stage disease probably would benefit from a device because the EF is dropping. Where that number is in HCM is a little unclear at this time, but I would keep your eyes out for that, and if you have a dropped ejection fraction, you want to have a conversation with your physician about if a device was appropriate. So being over 60 is a negative risk factor. That is true. In other words, what that means is if you survive to 60 with hypertrophic cardiomyopathy, the odds are much greater that you're going to die from something other than sudden cardiac arrest in HCM. But it is not completely protective. You have to look at the other factors. If you have two other risk factors and you're 62, that doesn't take away the fact that those risk factors exist. But if there is, a mild risk factor, and you've made it to 62, maybe, your grandfather died at 38, and you're 62. You have to balance that. And again, a specialist will help you make those decisions. I didn't even look at the rest of the question, and there it was, where your father died at 47 from VF. So again, what I just said, your father's HCM and yours are going to be different because he was older than you and he lived in a different generation and he wasn't assessed and he wasn't managed. You are assessed, you are managed. So I would not worry too much if you're seeing a center of excellence and they're telling you no device, because that's the only risk factor. There could have been other factors involved with dad's care. If you had multiple family members, I would probably look at it a little differently. So there you go. And thank you. This was a little bit harder than my normal talks because there's a lot of data collection involved with this one, so I'm hoping you all found it informative. Any other questions about sudden cardiac arrest risk assessment? Somebody asked me in a private message what age you should start risk assessment. You start risk assessment when there's a diagnosis. Genetically positive people don't need to you don't need to get assessed for sudden death if you are just a gene carrier. If you clinically have HCM, that's when we start assessing for risk. Joan, you're more than welcome to contact the office and we can discuss anything specific to your care that you might need our help and guidance with. I'm happy to help you. Any other questions on sudden cardiac arrest risk assessment? I have a little drink while you're all typing. Having a shaky tacrolimus day. Hate shaky days. It happens. The fun of life post-transplant. Oh well. Well, no questions. It's the big topic. Sudden cardiac arrest. What else can I tell you about sudden cardiac arrest? I think that the next iteration of the guidelines document. Well, hello, Debbie. We hope you're feeling better. I know you had a rough week, but you're on the other side now, and you joined the SCAR Club. Welcome. Bio oil. Swear to God, it's made all the difference in the world for me. Silicone stick and bio oil help scars fade. From ICDs too. Any other questions? I'm going to wrap up here in just a minute. If anybody has questions that they don't want to ask publicly, by all means email us at support@4hcm.org, and we'll be happy to address your questions. Going once? Going twice. Yes, you're seeing a rare hair up Lisa day. Don't normally do that here. Yay, getting released. Good for you, girl. Told you got this. Okay. I will give it one more second because I have a feeling that there's somebody there that has a question. I knew it. Parent with HCM, what age should screening start for children? As soon as there's a clinical diagnosis. Okay? They diagnosed them with HCM at 10, you risk assess at 10. And then you do it again at 11 and at 12 and at 13. For the young ones, you're doing this every year. I don't like the 24-month risk assessment thing. So what do you need for a risk assessment? You need the Holter to know if there's NSVT or an event monitor. You need a stress echo to know if there's obstruction. You need an echo. You need an MRI. And you need to know a really good family history. So when you have all of those pieces put together, you'll be able to have enough data to make a wise decision off of. If you're missing any of that data, you don't have the information to make the choices on. I will tell you some of the sadder stories that I've ever heard where people would go to a center of excellence, get an assessment, and then go home to their community cardiologist who was following them, but never did another risk assessment, and they have a cardiac arrest. And in one case, I will say I believe that there are things that are worse than death. And for a young father to lose his neurologic function to the point that he has a 15-second memory and doesn't remember his own children, I think that's far worse than death. So please make sure you keep up on these evaluations. I know it's difficult, I know it's costly, and I know it's stressful, but I'd rather you find out and get the treatment that you need than not find out at all. So please keep up on them. Okay. Any other questions before I go away? I got another big meeting to catch up on today. Got my UNOS meeting at 4. Scary stuff. So next week, we are going to talk about genetic testing because I had a really good question the other day. Somebody said, hey, where can I go for the best deal on genetic testing? And, last year I was a little busy, so I really didn't keep up with all my data. So I went back and I revisited all the genetic testing companies out there, what they're offering, what the profile or the platforms look like, what the testing looks like, and what the costs are, and whose insurance they take. And I'm doing an assessment of that right now. And I should be ready to have at least a conversation with you about changes and options and new companies that are available, as well as is it better to do your genetic testing in the hospital that you're being seen at and let them do the billing, or is it more cost effective to go directly to a genetic testing company and work with them directly? So depending upon your insurance company, these might become issues. So we'll discuss that more next week. But I got a little data collection to do on that so I can do my homework for you and report properly. And on that note, I'm going to wish you all a great day, and I look forward to talking to you in a week or so, or catching you on Facebook. And again, would you all do me a favor? When I tell people to call the office, I normally am using my cell phone, which is in front of me right now, and I am hitting the audio and say, just please contact the office or contact the HCMA. If I fail to put a phone number on there or contact information, point people to the top of the page or to the HCMA website for all of our contact information and means of contacting us. It gets really long to have to write it all every time I say, just call us. That would be very helpful. Rita, we're going to discuss that next week because I got to get going now. But I think you'll find some answers quite interesting. And I think you're going to find that we've evolved in genetic testing to such a point that it might actually be affordable to do a cash pay on some of these if insurance isn't willing to pay. And there's your cliffhanger until next week. Bye-bye.